Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today I want to discuss a subject that came up in a patient discussion a couple of weeks ago, and I see this actually on the forums over and over and over again. And that's the subject of taking a daily aspirin, like a low dose 81 milligram aspirin. Some people take 100 milligrams of aspirin, depending on what country you're in. But the idea is that this is going to somehow reduce your chance of clotting. It's a way to mitigate some of the perceived risk of an elevated hematocrit when guys are on testosterone therapy. So let's unpack this a little bit. I'll throw some science at you, and as always, let you make this decision yourself. As always, I think obviously you should talk to your doctor about it, but aspirin doesn't do what you think it does. I'm going to cut to the chase here. So aspirin is thought of a lot of times as a blood thinner, okay? And there's this fear in the TRT community about, quote, thick blood. So increased blood viscosity with elevated hematocrit. And it's true, viscosity does increase as hematocrit increases. But there's this fear, and it's an unfounded fear in the vast majority of cases, that particularly at the type of hematocrit levels that we often see with injectable testosterone, hematocrits, between, we'll just say 50 to 55% are not uncommon. There's this irrational fear that there's this big thrombosis risk that, maybe I can offset that risk by taking aspirin. So many of the guys I know that take aspirin every single day, they're not doing it because their doctor told them to do it. They're doing it because they heard on a forum that it's something that they can do. So I want to unpack this a little bit and discuss some of the science of aspirin, because I use aspirin every single day in my hospital medical practice. But I think I'm going to make a convincing case today that the vast majority of you guys who are taking aspirin for these relatively minor and modest hematocrit elevations, one, it's not doing what you think it's doing. Two, it's not lowering your risk, and it actually is exposing you to potential harm. So let's talk about this a little bit. So I'm not going to go into all the data on secondary erythrocytosis, which is what happens obviously with testosterone therapy. You get increased red blood cells. You do get some increase in blood viscosity, but the vast majority of the data, especially in otherwise healthy men, does not show an increased thrombosis risk. So when you're taking an aspirin every day to treat increased blood viscosity or quote thickness or elevated hematocrit, you're not really treating what you think you're treating. The reality is you're treating your own anxiety in the vast majority of cases. So let's talk about aspirin a little bit. Aspirin's been around forever. So for thousands of years, mankind has been using aspirin in the form generally of willow bark. I think there's some other natural sources as well. This goes back to ancient Egypt, Sumerians. Hippocrates himself wrote about the use of aspirin to reduce fever in what was probably malarial type illnesses. It was actually synthesized in 1897 by a chemist by the name of Felix Hoffmann, who worked for Bayer. And that's when commercial aspirin came on the market. But it's been known since the 1700s that extracts of willow bark could be used to mitigate fever in a whole number of different illnesses. So this goes way back. Mankind has been using aspirin for millennia. So how does aspirin work? It's actually relatively complicated, and it basically involves inhibition of the synthesis of a whole series of chemicals called prostaglandins, which act as various messenger systems throughout the cells. They have a wide range of effects. But aspirin, like many other non-steroidal anti-inflammatory drugs, inhibits two enzymes, COX-1 and COX-2. This is the little diagram here where phospholipids are transformed into free arachidonic acid. Some of you may have heard of arachidonic acid. The COX-1 enzyme and the COX-2 enzyme then come into play. They produce prostaglandin G2, prostaglandin H2, which then out in the tissues gets produced into a whole series of different prostaglandins. Prostaglandins are involved in a whole series of bodily processes, mainly related to pain, inflammation, swelling, but also platelet function. So this is what we're going to talk about when it comes to aspirin. So aspirin effectively inhibits platelet aggregation and platelet function. It does so permanently. So once a platelet comes into contact with aspirin, that COX enzyme is permanently inhibited for the entire length of life of the platelet. So, you're given, generally it's about 10 days or so. So it's permanent. It's irreversibly, that platelet is taken out of, essentially, it's not taken out of circulation, but it is effectively taken out of circulation because it's no longer able to participate in the clotting cascade. And that's why aspirin can be effective in people who are at higher risk for thrombosis. And like I said, I use it almost every single day. Patients that come in with heart attacks and ischemic strokes, they benefit greatly. Aspirin, without going into too much detail, is still, even though it's been around for so long, it's still one of the most effective drugs that is used in the adult medicine world for the treatment of heart attacks, both acutely and in prevention. The same with strokes. Even with all these fancy new drugs that are out there, there's very few that are as good as aspirin. So it's an oldie but a goodie. Okay, so the big question is, does aspirin change blood viscosity? Can you treat, quote, thick blood from a high hematocrit by taking aspirin, either low dose, high dose, etc.? So this has been looked at actually fairly extensively. And this is a good article here from BMC Neurology. It's dated 2019, so it's relatively new. It's called the effect of warfarin versus aspirin on blood viscosity in cardioembolic stroke with atrial fibrillation, a prospective clinical trial. So a lot of patients with atrial fibrillation, especially if they're elderly or have a bunch of other comorbidities, they qualify for anticoagulant therapy, usually with, we used to use a lot of warfarin, but now there's a whole new series of drugs. They're not that new anymore, but DOACs, these are your Eliquis and Xareltos and things like that. Those are brand names. You may have heard of those. My dad takes Xarelto for his atrial fibrillation. So this prevents the formation of clot within the atria, which then obviously embolizes and can cause a stroke. So it reduces stroke risk. The downside of these drugs, of course, is they put you at risk for bleeding, and all kinds of different bleeding, not just bleeding from trauma, but spontaneous intracranial bleeds and gastrointestinal bleeding, which is the main concern. But so I digress. So in this study, they looked at the differences in blood viscosity in groups that were treated with aspirin at various different levels. And what did they find? I'll read the conclusions for you here. So this is the big one. Aspirin does not significantly alter blood viscosity. So if your blood is thick, quote, thick before taking aspirin, it will be equally thick as in terms of measures of viscosity when you take any dose of aspirin. So I'll read it again. Aspirin does not significantly alter blood viscosity. Multiple studies, including a randomized, double-blind, placebo-controlled study and a clinical trial comparing warfarin and aspirin, which is this one, found no statistically significant difference in blood viscosity before and after aspirin. So it goes on to say, as for aspirin, the previous study showed that whole blood viscosity did not change at any dose of aspirin. In the present study, the blood viscosity values at all measured shear rates did not show any significant change after aspirin treatment, which is similar with previous studies. So this is just one example, but there's a lot of different studies that have shown this. This is a chart from that paper where they look at the shear rate, how quickly the blood is moving. And it doesn't matter what dose of aspirin you're taking, aspirin has, and what the shear rate was. There's no difference between no statistical difference, I should say, between the baseline in terms of viscosity and then after treatment with aspirin, regardless of the dose of aspirin. So aspirin is not a, quote, blood thinner in terms of if you're using this to alter your blood viscosity, in particular from elevated hematocrit, aspirin has no effect on this, none whatsoever. So again, why are you taking it, right? You're taking it to alleviate your own anxiety. You're not taking it to actually impact blood viscosity. So that doesn't mean aspirin isn't helpful in certain circumstances. So let's unpack this a little bit. This has actually gotten more complicated in the last few years. When I was going through my training 25 years ago, it was sort of a no-brainer. Basically, if you turn 50, many physicians decided, they said, well, why don't you just take a baby aspirin every day for your heart, for heart protection? Okay. And there's still physicians that do that, but that's no longer really in line with the evidence. And the reason that the recommendations have changed is I think an increased an appreciation for the fact that aspirin, even baby aspirin itself, conveys a certain amount of bleeding risk. And as you get older, that bleeding risk increases. It can increase also with other comorbidities, but definitely there's an age-related increase in very, very serious, potentially fatal bleeding. The two main sources being in your brain and in your GI tract. I see this, I'm not going to say every single day, but multiple times per week in the emergency department. Elderly people, and sometimes younger guys too, coming in with very serious gastrointestinal hemorrhages, usually from an upper source. So we're talking about gastric and duodenal ulcers, occasionally with perforation that makes them critically ill. And we're having to transfuse these people a lot of blood. We're having to get them to the ICU, oftentimes into the operating room, and get a hold of my GI and surgery consultants as quickly as I can, because many times these people are they're literally bleeding to death and need to be treated immediately. So it's actually a really, really big deal. So having said that, the recommendations now from the U.S. Preventive Services Task Force is to calculate your 10-year risk of cardiovascular disease, and then based off that risk, if it's greater than 10% that you're going to have an event over the next 10 years, then it makes sense for you to take aspirin. If it's less than that, then actually the risk of an adverse bleeding outcome actually outweighs the potential benefit of getting aspirin. So where can you figure this out? So if you just type in 10-year risk calculator, obviously into Google, you can find it. But this is a website here, clincalc.com. This is your ASCVD risk factor. It looks at your various different risk factors and then spits out a number. Like, this is your risk, or, based on previous population studies, this is your risk of having an event over the next 10 years. So it's fairly simple. Put your gender, your age, your race, total cholesterol, HDL, systolic blood pressure. Are you receiving treatment for high blood pressure? Do you have diabetes? Are you a smoker? Boom. You put that in, it'll spit out a number. Okay, your risk is 3.5%, for example, over the next 10 years. Okay, probably don't take aspirin. There's not going to be, the risk benefit ratio is not in favor of you taking aspirin. So here's the recommendation again. It says for adults age 40 to 59 years old with an estimated 10% or greater 10-year cardiovascular risk, the decision to initiate low-dose aspirin for use in the primary prevention of CVD, cardiovascular disease, in this group should be an individual one, right? So sit down and you talk with your doctor and you weigh the pros and cons. For adults over the age of 60, this is where the big changes come. Do not initiate aspirin for the primary prevention of CVD if you're over the age of 60. These are the current recommendations, okay? So now there's going to be a lot of individual variation here, and this is why I'm not giving you like individual medical advice. This is something you have to talk to your doctor, preferably your cardiologist, about. The cardiologist to understand this inside and out. And be able to determine whether the risk benefit is there. If you've had a prior heart attack and you just got 3 stents a year ago and you're 75, well, it may be favorable for you to take aspirin every single day in a low dose format to preserve the patency of those stents and to prevent you having a second event. So, and this is what this graph here is all about. So this is in high risk individuals. So how much does aspirin actually help lower risk? And so you can see here, there's a control group in gray and the people that got aspirin in yellow, and this is adjusted percent of vascular events. I think it's useful to look down here at the benefit per 1,000 patients. So for each of these, you have to treat, if you treat 1,000 high-risk patients with aspirin who have had a previous myocardial infarction, 33 of those stand to benefit statistically. So it's not like all 1,000 benefit. There's 33 out of 1,000 that benefit from taking an aspirin every single day. And of course, the benefit is they don't have another heart attack. So that's actually, it doesn't seem like it's very much, but that's actually, in terms of medical therapy, that's actually not too bad. So you can see it again here. So previous MI, acute myocardial infarction, its benefit per 1,000 patients is 38. If you've had a prior stroke or mini stroke called a TIA, It's 27 patients out of 1,000 benefit. And you can see there is benefit here. There's no question there's benefit. The problem is there's also risk. So let's talk about that a little bit. And again, those of you guys, there's a whole bunch of you guys that are in your mid 40s, you're running around with hematocrits of like 52, 53%. And you're thinking, oh my God, I'm going to get a stroke. I'm going to get a heart attack. I know what I can do. I'll take a baby aspirin every day. Okay. So what is the risk? It's a good question. So it's going to vary, obviously, from individual to individual. But this is a study here that looked at this, PLOS One, bleeding risk with long-term low-dose aspirin, a systemic review of observational studies. This came out in, it's 2016. So it says here, in cardiovascular disease, primary prevention studies, very low-dose aspirin. So we're talking about 100 milligrams or less. Typically in the U.S. and the Western world, it's the little 81 milligram, Bayer aspirins. So very low dose aspirin use, increased major gastrointestinal bleeding. This is overall risk by 58% relative risk. Okay. And hemorrhagic stroke. So bleeding in your brain. So you get a little aneurysm or a little vessel that leaks and bursts, increases by 27%. And this is a graph here. Remember how I said it's obviously like there's an age related component to this. Well, this shows this quite beautifully. So this is for upper GI bleeding, which is obviously extremely serious. Lower GI bleeding is serious too, but this is for upper GI bleeding. You can see there's a control group. And then as you move to the right here, as you get older, so if you're below 50, I mean, the risk of anything bad happening to you is obviously going to be quite a bit less than it is, let's say, when you reach, over the age of 80. So a lot can happen in 30 years, obviously. So if you look at the rates of upper GI pain, so presumably like aspirin-related gastritis, uncomplicated ulcers, complicated ulcers, so like perforated ulcers, that sort of thing, it starts to go up, and it goes up significantly, especially as you start getting into the ages of like 70 to 79, and obviously when you hit 80. So this has to really be an individualized decision between you and your physician, whether the risk-benefit ratio is there, because the bleeding risk is not inconsequential. The other thing that's really not mentioned in any of these studies, but it's something that I encounter on a fairly regular basis, is patients come to me a lot with really severe blunt trauma. And I'll share a case with you that I actually just had this week. So out here in the UAE, there's a really big delivery culture. It's actually great. You can get almost anything like delivered to your house within an hour, groceries, food, etc. It's actually pretty incredible. But the way that happens is there's all these guys out on these little motorcycles, and they're zipping around all over town, and the traffic is pretty nuts. If any of you have ever been to UAE, especially like if you've been to Dubai or Abu Dhabi, the highways can get a little bit nuts. So not surprisingly, these guys get blasted sometimes on the freeway at high speed by cars who just don't see them. There's all sorts of accidents. So I had a young guy come in his 20s, got just smashed. I don't really know exactly what happened, but he was on a motorcycle. And the fact of the matter is, it doesn't matter how good of a motorcycle driver you are, you lose every time. Every time. It doesn't matter how good you are, you are going to lose versus a car. And this poor guy lost big time. So he came in like obtunded, major facial trauma. He was not protecting his airway, so I intubated the guy right away. He had an obvious like scalp hematoma. Even though he was wearing his helmet, he had both bones sticking out through the skin of his arm. His hip was shattered and dislocated, so had to work pretty hard to get him stabilized. But he had, on a CT scan, had a CT that, this was not his CT, but it kind of looked like this, right? So all this white stuff is blood. So this is a big epidural hematoma. He actually had a subdural, but I like this picture, so I'm going to show it to you. So imagine if this young kid, I call him a kid, he's in his mid-20s. Imagine this guy comes in and he has been taking low-dose aspirin. He's on TRT, he's been taking low-dose aspirin to help mitigate this perceived, largely imaginary risk of thrombosis. And this happens to him. So as bad as his other injuries were, he's going to survive all. Those are like, they were just severe orthopedic injuries. Thankfully, he didn't have any major like solid organ injuries, didn't have a spleen that was bleeding. He didn't have a hematoma or anything like that, even though he had rib fractures, but otherwise his chest was okay. He had bleeding in his brain, and that's why he was unconscious and was at risk of losing his airway. So imagine if he's on an antiplatelet agent. So the size of intracranial hemorrhage, whether it's a subdural or epidural, size matters, okay? So you do not want hematoma expansion in your brain at all. So it's crucial. There's a certain amount of damage that has been done here, and it's critical that this hematoma does not expand and that he doesn't get any further compromise of what's left here of his brain. So if he had been on an aspirin, he's going to continue to bleed a little bit more, obviously, and sometimes potentially a lot more than he would have if he was not on aspirin. And this guy, thankfully, to the best of my knowledge, was not on aspirin. But he still had to go to surgery, had a bolt put in his brain, okay, which is a mechanical device that directly measures the pressure in the brain. And he's being watched very closely by the neurosurgeons. And obviously he's gone to the operating room, or he's going to be going to the operating room multiple times to fix all of his orthopedic injuries. So, this stuff happens. And, again, you can be the most careful driver in the world and still end up in a severely traumatic injury, despite, you being extremely cautious. So if you're taking an aspirin every day and you get a big hit on the head like this guy had a skull fracture, of course. You need every advantage that you possibly can if you want to come out of this as a functional human being and would like to still be able to walk, talk, dress yourself, and not be in a diaper or a wheelchair or in a rehab facility for the rest of your life. So I'm not trying to be dramatic here, but these are some of the untalked about risks of taking aspirin every day, especially if you're a young guy that likes to go out and do contact sports. If you're into MMA, you do not want to get punched in the head, or you don't want to get a full kick to the head and have aspirin on board. It just doesn't make sense, to do that. So, and it's not really talked about in any of the studies. So the take home I want you guys to have, there's a few things. One, so the overwhelming amount of evidence out there does not support the fact that these typical hematocrit elevations that we see with testosterone represent a thrombosis risk. So just get that out of your mind. And again, you can watch some of my videos on this. You can watch some of the videos I have on donating blood. And there's many, many other physicians out there that have put out quality content that say exactly the same thing. This is not really something you need to worry about. So don't take aspirin for that. Aspirin does not alter blood viscosity based on the majority of the studies that are out there. So if you're afraid of thick blood, if you had thick blood, taking aspirin makes no difference. Doesn't make any, you're not treating anything other than your own anxiety. Aspirin is beneficial in high-risk people, but again, you have to weigh the individual risks and benefits. Don't make this decision on your own, guys, because you don't know the literature. Trust me, you don't know the literature as well as your cardiologist does. Your cardiologist knows it backwards and forwards. Hopefully your internist and family physician knows it as well. But it's changing all the time. So this has to be done. It's an individual assessment. Don't just go take aspirin on your own. Just because aspirin is over the counter does not mean that it's safe and that everybody should be using it. Okay, aspirin it can be extremely dangerous. Okay, and it's I see a lot of misadventures with aspirin that maybe I can share that in a different video. But the other point is low risk individuals. So like probably the majority of you do not stand to benefit from taking aspirin every day. The risk benefit ratio does not favor you taking aspirin. So again, I'll just reiterate, if you're entertaining this, if you want to know if you're a candidate for aspirin therapy, if this is something you should be doing, talk to your cardiologist about it, talk to your internist, talk to your family physician, talk to someone who knows the data well and can give you good advice. So that's all I have for you guys today. Let me know what you think about this. Those of you guys who are on aspirin, those of you who don't take aspirin, or if you've had complications from aspirin therapy, let me know about them, because I'll tell you, I see them a lot. I see them quite a bit. Even guys who come into the emergency department with like routine lacerations, I can tell that they're on aspirin. As I'm sewing them up, I can just tell that they're on aspirin because they're just bleeding and bleeding and bleeding. And it becomes a challenge sometimes to keep the field clean so I can see what I'm doing. But I can tell. I don't even need to ask them. I can tell that they're on aspirin. So most people that are involved in any sort of surgical procedure will tell you that as well. So hope you guys are well. I will catch you next time. Bye-bye. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.